scientific committee of the Dutch Society of Plastic Surgeons, which I'm one of the members, and my co-host tonight, Juliette Hommes, who is a plastic surgeon and a fellow in hand surgery in Maastricht at the moment. And we have also Reinier Feitz from the Arthroplasty. He's one of the board of directors, and you kindly let us use the Arthroplasty Zoom account, so we are very thankful for that. And he's also a plastic surgeon working at the MST in the Netherlands. I'm honored to have three guests today, which I will later introduce you, and it's David Ring, Rudolf Polman, and Reinier Feitz. The purpose of this webinar was that as part of a national project to find out about knowledge gaps in the treatment among all Dutch specialties, we investigated in a systematic way all the guidelines for the treatments in our specialty to find knowledge gaps. And then we classified these knowledge gaps in priority lists of 10 top priorities. And all plastic surgeons participated in this list, creating this list, but also health organizations and also patient groups concerning these problems participated in creating this list of knowledge gaps. And interestingly, there were about 4 of the 10 top priorities in knowledge gaps in our specialty in the Netherlands were within the hand surgery. And we felt that as a science committee that we felt responsible to further investigate and further enhance and encourage people to research in these top knowledge gaps. So that's why we started this webinar series, and I'm really excited about the program and about the speakers. And I would like to share already as a small provocation. I learned this from David when we traveled to one of the, I don't know if you remember, David, that was in the New England Hand Society meeting. We traveled there by car, and you already mentioned that you would like to be a provocateur during the meeting to encourage discussion. And as part of that principle, I want to share one of the science of variation group that I participated in, that I had the chance of helping create during my PhD in Boston a couple of years ago. So what we did, I will shortly start, and Hemi, you can move to the next slide if you want. About 10 years ago, we started during my PhD about doing classification research. And what we found, and basically this is one of your quotes, actually, David, that I found, and it was about Paul Farmer, who speaks about the differences in treatment options around the world, and that's unwelcome, basically, to have a different treatment in one area for the same problem in the other area. And Paul Farmer is a philanthropist and also a physician and head of the department of the World of the Global Health in the Brigham and Women's Hospital. You can move to the next slide. So what we did was basically do simple variation studies back in the day, when you would go to a physician and ask him to classify about 100 cases to find out about the reliability of these classification systems, which was already very tedious and a lot of work also. And what we found is that there was already so much variation that we couldn't really explain. And for example, this is a study, what I showed here, that we performed about 5 fracture patterns around the elbow in 73 observers and within 50 cases, and we only found a moderate agreement. I move to the next slide, please. Another example is a small study that we did on the classification of union rates among distal tibial fractures that were treated by open reduction internal fixation. And we ask a very simple question: is the fracture healed? And you can already see here that a large part did not agree, and that was very interesting. So we thought that even this variation would be something to further investigate. Next slide, please. But the problem was at that time, this is also the purpose of starting this research, and you can move to the next one to gain some time. So the problem was that, as I mentioned earlier, it was very difficult to do variation studies because it was tedious, it was time consuming, and not always a lot of fun. And we started, this was about 2006, 2007, I think, when we first started doing this. And we first created web-based studies, and you had to call for a web designer, which was very expensive, and it took also a lot of time to create those surveys. And there was a technical problem that we couldn't upload, for example, CT scans, and we had to figure out a way to make it more accessible, easy, and more cheap, because we didn't have so much money for doing these studies. So what we did actually was creating movies from the CT scans, and we uploaded them to YouTube, which is of course accessible by all web browsers in every country, and which was free. And then we had the possibility to add HTML code in SurveyMonkey, which allowed us to use the movies within our questionnaires. So basically these technological solutions or advances made it possible to start the online observer studies. And we started with a really small group of enthusiast friends, and we invited these, let these friends invite another friends, and that's how we started to get a large group of enthusiast surgeons who wanted to participate in these studies. And next slide, please. And this is how it looks like technically. So you see here two examples of one of the, on the left side, you see cases with x-rays, and you can click on them and look into them. And then below you see the questions. And on the right side, you see one of the studies which has the CT scans and 3D reconstructions. And you can actually click on the movie and then scroll back and forth with your cursor. So this was something that was new, but couldn't been done before. Next slide, please. So one back, please. Yeah, and one further. Yeah, this one. So basically, what was one of the successes behind this group was that it was online, it was on demand. Anyone could do the study whenever they wanted. It took little time, little effort. And what I didn't expect, but what really made people enthusiastic about this was that they could participate in creating science. And even a lot of hand surgeons, for example, they work in very remotely in small private practices. They didn't have the infrastructure to do research. They don't have research coordinators. They don't have access to scientific support. So they could actually help by doing these studies. And what they also, a lot of people mentioned, is that they actually learned from these studies because they were questioned themselves during the study. So they figured out that they would classify, for example, or treat some cases differently from the start till the end, and that would make them even learn something during those studies. So that's one of the great successes, is the enthusiasm and the camaraderie in the group, also by all the researchers that were able to start these studies and learn how to write papers, how to execute these studies. So we have a large group of PhDers, research assistants and coordinators who are all involved, and make it a lot of fun actually to do this type of research. So technology helped us being able to create this, and the network and the enthusiasm of people made it even a bigger success. So next slide. Yeah, this was the last one. So I want to end with this presentation, and one of the main things is that what I think is that it allows people to instead of only pass on information as a physician, but also to help create science. And there's no better example, I think, for our first guest and first speaker, David Ring, now working as also a hand surgeon, and now working as a professor in Texas, in Austin. You are one of the big examples for me as a co-promoter and also a mentor during my training, of how you can make science and create science during a very busy work as a hand surgeon in a hand clinic. And I would really want to ask you to share your screen and start your presentation. Thank you.
Maybe in the meantime, I can, while David unmutes himself, point out that people that are watching us, you can ask questions through the Q&A that's in the lower end of your screen. You can ask a question, type it in, and we will discuss it, or use the chat function to let us know who you are, where you're from, and we're really happy that you're here from all over the world. Thank you.
Well, thanks for inviting me. I love to travel. This is the COVID version of travel. It's nice to connect with colleagues around the world. I appreciate this being done in English. I don't ever take that for granted. Dutch speak such good English, and I benefit from that. Let's talk about how to be productive in science. You know, there's this guy named John Ioannidis who I really admire. He's a Greek guy who ended up in Stanford, and he's a kind of a science debunker. You can look up some of his studies and just enjoy, or his editorials. But he did this study where he looked at hyper prolific authors, and I ended up in that list. And he asked me to give a commentary of, and it was not a positive thing. Obviously, this guy's a debunker. He's like trying to figure out how and why this is happening. But he asked me to give a paragraph for the paper, and it's published, I think, in BMJ or something, of how I became a hyperprolific author. And the answer is people like Chiri, and that's the only way it can happen. And it's not really me that's a hyperprolific author. Really, it's the team. It's the team. So, and along the way, actually my first PhD student was Job Dornberg, who named it the Science Factory, and we'll explain why that is. So here's me as a third-year medical student in San Diego. My house is right behind that, like right next to that big tree, and then the medical center is back over my right shoulder. And third year of medical school, I got exposed to the orthopedic department that was led by Wayne Akeson. And this guy was, I didn't necessarily, these are the kind of things that you pick up that you don't really realize you're picking up. But he's the guy that made curious people. He made scientists, but not like lab rat scientists, just not accepting the status quo, realizing things could get better, and being always curious and investigative. And he did that with, if you look at the people that came out of his department, it's a who's who in orthopedic surgery. It was a real heyday for a relatively, he began his job in 1970, and by mid 80s, it was one of the best programs in the country. This was my mentor in my third year of, I stepped into my first orthopedic rotation late in my third year, and Dennis Wenger, a pediatric orthopedic surgeon, said, "Hey, do you want to do a clinical study?" And I thought I could only do lab studies. I thought that was amazing. So I jumped in and ended up doing a case report with him, a case series, and then a couple of review articles and book chapters, all on what's called discitis. I think it's still called discitis, but what we found is really just pyogenic vertebral osteomyelitis in kids. So my very first experience was to go and look at what other people were writing and other people were saying and teaching, and find the holes in it. There were some very important holes in what they were writing. For instance, they were saying it was due to trauma. They were saying that it was not always infectious, and it was based on misinterpretation of data, like negative cultures, which we now know there's always negative cultures with biopsies and infection and such. So it was a very, Dennis told me that I earned a PhD in discitis over the 3 or 4 years I was writing about it. So he sort of got me going. And then, of course, when I got to Mass General, I'm skipping Alex Vaquero, who's now chair at Jefferson. He's the guy that showed me how to keep a lot of balls in the air and juggle a lot of studies at once. And then when I got to Mass General, the only attending I saw at 4:30 in the morning on rounds was Jesse, and he kept me fueled and got me going. In 2002, this guy Job Dornberg came around and he said, I want to get a PhD, and I knew what that was because I noticed that when I was studying elbow fracture dislocations, there'd be 6 or 7 studies coming from Josephson, and when I was studying clavicle fracture, there'd be 6 or 7 studies coming. So I kind of had a sense that there was a degree that people were earning or something motivating them. And so Job said, yeah, I'm going to come. I just need a stipend. I can cover a bunch with grants, and I bring my own benefits. And I thought, why would I not do that? So I took him on. And what was great about Job, what still is great about Job, is he just gets people excited. He brings people in. He's a great organizer. So soon enough, people were coming to do their medical student rotations for 3 to 6 months. The next PhDs were lining up. He was able to create this science factory of people coming in. And we would always go to Jesse's house for journal club. And you can see we're all sweaty, wearing our boots, having just played football. And, it was fun and work, always fun and work. And that was sort of the tie. Thierry and I were mentioning Santiago, who's on the left of this, came from Colombia, got into the US, now is an oncologic orthopedic surgeon at Mass General Hospital at Harvard. So that's quite a story. It's quite a science factory story. Chris Forthman, the other guy, is at Union and Curtis Hand Center in Baltimore. So it's nice to see people going on and making great careers. Here's me before I got my professorship, so I'm not in my gown and hat at one of the ceremonies, and it's great to have a clinical degree that recognizes research makes people want to do more research. It also helps that it's hard to get into orthopedics and plastic surgery. This is everybody at my house in Boston shortly before I left. And the team got pretty big enough that we had to branch out to foot and ankle, spine, trauma. And we have, there's a couple of Iranians in the mix there, and we've got a steady stream of Iranians coming in as well. And if you, Nick Van Dyke is on the left bottom of the couch. So there was, we got Nick there as well. Yeah, back to the fun. This is at Jesse's house again. People love to, and Texas is equally fun. If we can get past the pandemic, there's barbecue and live music and stuff. So it's always been there's always been this part that's travel, social, practice your English, broaden your horizons, but also reach your ambitions. And this is something that I got from Job's description of how this works. And he calls it the slipstream effect. The way that we get a lot of things done is that when you come if you come to Boston or you come to Austin, the way you got started was you picked up a project that somebody left for you. So they started it, but they couldn't finish it, so they left it. So you hit the ground running. You were already working on something. And then as you got skills, you then trained somebody else. So if there was somebody there for 3 months, then they trained somebody who was new. PhD students trained everybody and train everybody. And so there's this slipstream effect where it's a lot quicker to get up to speed on statistics, study design, IRB stuff, peer review. You just have a lot of help around you all the time, and it doesn't rely all on me. That's how we get a lot of things done. So Thierry had that role. He was new, so he had to be taught. Then he was the PhD student teaching everybody else. By the end, he was running the whole show. And that hierarchy is really what makes it work. It's not intuitive to people. They come in and they think, this is my project, or how do I get more projects? But what people need to learn is that if you collaborate and you're selfless and you don't really worry about getting credit here or there, but you just worry about getting the work done, you're going to end up with a lot more publications. So people would come in, the people that really got it would come in for 6 months and leave with four to six publications. The PhD students all left with 24 publications. And so that's really the key elements of what it's about. And then back to the fun, and this is us Job set up this thing where something called Trauma Platform, where we all landed in in Nottingham and rode bikes up to Edinburgh for the Edinburgh Trauma Symposium. And I took the mountain bike trail. So the points of discussion are that I love science because I don't trust what I see and I don't trust what people tell me. I'm very curious. And so I want other people to love science. So I try to make it fun, easy, non-tedious. Don't waste your time. Try to make it help. You're there for a reason. Medical student rotation, PhD, residency, whatever it is, we're going to help you reach your ambitions, and that's always first and foremost. And just my joy is future academicians, but I'm satisfied with people who are just good critical thinkers. I'm happy to take any questions.
Great. Thank you so much, David. Very inspiring talk, and really great to see all the pictures from back in the day when you even were a resident. Cannot believe it. All right. Do we have some questions, Juliet, from the Q&A, or?
Not yet. They're still warming up, I think. So I have a question. What we see in the Netherlands is that, for example, that there is a lot of different disciplines involved in hand surgery, for example. And you've been working with plastic surgeons or plastic surgeons to be, and also orthopedic surgeons. Have you experienced differences in thinking, but also in aiming within the hand surgery department, how to reach the same goals?
I think everybody, it's good to have different perspectives. I think it has a lot more. I'm getting people at a pretty junior level, right? So they're usually medical students or nearing the end of medical school. They don't really know much about hand surgery or plastic surgery, orthopedics yet. So it's more about helping them explore that interest, and it's really about getting in the science mindset and the collaboration mindset. Along the way, we've had a few people struggle with it, and you know, some people were having one or two having personal issues, one or two just couldn't work as a team. And those are the ones that potentially can ruin your culture. So we purposefully said, okay, you can work alone and you work over here, and tried to keep them from ruining the culture. Thierry, do you remember anybody that came when you were there? I know, well, Kim had a little personal issues, but she got her PhD. But so that, you know, sometimes these are young. That's another thing. Like, we have to look after people. People come to us very young and they're far away from home. And the first and foremost is their health. And we have had people that one of my first medical students here in Austin, same thing. He's having family troubles. You know, go home, take care of it, don't worry about it. Family comes first, you come first. But other than that, people hit the ground and they're kind of, how does this work? And then about a month or two later, they're like, this is awesome. So plastic surgery, orthopedic surgery doesn't matter.
Okay. David. There's a couple of people that are in the audience, and we recognize all the names, of course, that are also in setting up networks and in leadership positions. What is from my experience, when you get a lot of students, it's hard to keep them focused, and they really need some leadership. And you've been growing into somebody coined the term the paper factory, and I think that's a tremendous compliment for what you've been accomplishing. But what is your trick on how to guide these students into producing?
Yeah, you know, it's the hardest thing about this. You know, one of the things I meant to mention when I showed the slide of Jesse is that Jesse couldn't do this. Jesse could not do this. Like he would go to something, you know, Thierry would be there. I'd say, Thierry can work on this project with you. But there's so much hand-holding when you first start that Jesse's like, forget about that. When I first got to Mass General, I was already seasoned writer and researcher. So he gave me a project and I did it. And he was like, oh, here's some more. That's what Jesse needed. I still, to this day, take very junior researchers right by the hand, and lead them through the very basics, email by email. Now, I wish I didn't have to do as much of that. Back in Thierry's day in Boston, I could rely on Thierry and Kim and Geert, I think it was, with your group, and they just took care of all that. I saw mostly the final product, and it was usually good. But it's because Geert had trained Thierry, and somewhere along the line, I was involved in training as well, but not like arm in arm and side by side. It was more by just overseeing the knowledge coming down. And so part of it is that people need to understand early on that that's how it works and be okay with that. Part of it is in the selection process, who enters the team. I'll often people will email me and say, I'm interested. I'll say, okay, and I'll send them, you have a task. And if I don't hear back from them, then they're out. Or if they, if they do the task, then I give them another task. And I want to see them, jump through a few hoops. One of them's like, study about how to do research and do the test that you have to do to require for the IRB. That'll weed out a lot of people. I'll say, go write me a one-page protocol on this idea, and then if they don't do it, they're gone. So there's a lot. Can you work by electronically? Can you work independently? Can you take direction? And if you can't, then you go over to the side. One of the things I also try to be very generous, because I remember when I first started, so I showed you Dennis Wenger. He's like, okay, write this case report. It took me a year to write that case report. I had writer's block. I was intimidated. I can remember all the intimidation. This is impossible. I can't do this. I have to be very careful. And I didn't have the skills. Now I have the skills where it just comes like riding a bike. But back then it was all scary, and I took forever. And so I realized that's the way people are thinking. I'm saying, just do this. Just do it and send me what you have. Like, don't try to make it polished. Just do it and do the methods and then send it to me. Do the results, then send it to me. Add the introduction and send it to me. And once they've done one paper, start to finish, or sometimes if they drop in, like I have a bunch of people starting right now, and I have one writing up a paper that somebody finished the data on. So now they're getting writing skills. They're going to get submission, peer review skills, while she's also making her own IRB proposal. So she's learning the skills kind of out of order, but she's getting those skills. And I want them to do that as soon as possible, because it just breaks up the intimidation. And then they go, oh, I can do this. And then they just get better and better and better at it. Thierry, is that how it worked for you?
Yes, I agree. I remember my first paper was also, it took months for me to write. And then the second one took about half the time. And then the second one again, half the time. And so it speed ups. And what I also realize now more, that one of the difficult things was getting into America, for example, with visa and all the funding that you had to write for. All that took a lot of effort and a lot of motivation, I think. So yes, that was, I think, a nice way actually of selecting people that are motivated. And if you do this, then you also want to make it a success. So you're intrinsically motivated to work, to participate, and to learn, and to share, and to collaborate. So I see that as one of the advantages as well, I think.
We have some questions from the audience. The first one is, how do you create a budget for the science factory, or do you have a budget?
I should have said that right from the start. So if you, like, orthopedic research in the United States is not grant funded. The number of people that have NIH grants, for instance, is probably on one hand. I'm talking about clinical research. Usually it's big consortia. Why is there so little funded research in the US? Because surgeons cost too much. So they want us in the operating room generating money for the hospital, for the department. That's what so they don't want you doing research. And if you do try to go on a grant and put your salary on a grant, good luck. The cap is like way below what surgeons make. So then your department has to take the money from somewhere else, and all your partners grumble. So surgical research is done on a volunteer basis. And some departments will funnel money in, but the beautiful part of this system is that it's based on volunteers. So all the medical students that come for 4 to 6 months are self-funded. We have here in Austin, we have undergraduate students who want to go to medical school. We have medical students who want to get into orthopedics. They're getting something out of it, but to make it worth their while. But we don't have the money to pay them, so we can't pay them. If I had to pay a PhD student full salary and benefits, that would be $70,000 to $100,000 a year. where's that money coming from? If I pay them a $20,000 stipend, I can scrounge up the money for that. So it's a really, people look at the system, and if there's ever a criticism of the system, and it's worth thinking very carefully about it, is who has access to this? Not everybody can volunteer that way. Not everybody has the means to volunteer. So it's a kind of inequitable system in a way. And I'm very aware of that criticism. I'm also very sensitive to the idea that we might be taking advantage of people. And so I check with everybody. That's one of the things I always check, like, I don't want you to feel taken advantage of because I'm getting a lot from you. You need to get an equal amount from this experience. And people say, I'm getting what I need. I'm getting what I need from this. I can't get this anywhere else. So, but those are the two issues. But this is research on a shoestring, and it's done on volunteerism. And I think you have to do it carefully and responsibly on volunteerism.
Okay. Well, thank you.
Thank you.
We have one
question?
more question? Yeah.
One last question.
Okay.
One of the residents needs some advice. How do you combine the research with clinical work? Because it's always juggling around.
Yeah, this is something that people have different styles on. Maybe the other panelists can talk about this when they get their turn. I find some people carve out a day, or maybe they do it evenings and weekends, but they need a quiet time. They need to sit and have quiet time. And I need some quiet time too, but I'm also doing it between cases. I'm doing it before clinic gets going. I'm doing it on the road, in the plane, in the back of that. People see me in the back of a meeting, typing my next paper. They say, Dave's working on another paper. I mean, it's finding time in those down moments, and it works very well for my work style, but it doesn't work for everybody. Thank you.
Thank you very much.
Thank you so much, David.
Thanks.
So we go to our next panelist, Rudolf. You can unmute. We'll introduce you. I know you already from a long time, from my intern years. I worked with you in the orthopedics department. I remember you went to Toronto after you finished your residency as an orthopedic surgeon, and you went to the McMaster University there. With one of the ground layers of the evidence-based medicine, Gordon Guyat. I hope I pronounced it well. And also Mohit Bhandari, who's one of the big ortho RCT researchers in the world. So I'm really excited to have you here today, and I'm really looking forward to your presentation.
Well, thank you, Thierry. Those were my mentors, and but I'm also mentored by the residents and the guys that do research with me, or girls. It's reverse mentoring, and I think that's one of the things. If you're in a growth mindset, then you really can enjoy doing research. That's what I wanted to add to David. And that, if you look at David's face, he's always enjoying research, and it also sparks from his emails. If you work with him, it's always positive and keep go-getter. So I think that's also one of the things you need to be living with the growth mindset. So thank you for the introduction. Nowadays I work at the OVG hospital in Amsterdam, but also at Leiden University Medical Center. That's where I was appointed my chair in health evaluation and in orthopedics. And so we do a lot of networks and evidence-based practice. So this is a pretty good topic for me. Oh, no, it's not moving forward. What's happening here? So, yeah, let me see. So this is the danger of trying to do Prezi on a Zoom meeting. So let's try this. So this is a slide from our report. I was on a committee that was trying to design a framework for doing research and to answer unanswered questions, because we have a lot of unanswered questions that are still open, and it's oftentimes the things that are just quite simple clinical questions that are unanswered, and they're not like knowledge gaps, because knowledge gaps sometimes can be in the knowledge of one single physician or a junior doctor. but these are unanswered questions. I think this covers it better, because if you have an unanswered question, you can design this into a research question and find a way to answer it. So we made this circle with healthcare evaluation, and then you have the innovation part of it, education and implementation. So this is not new. This is also from the evidence-based medicine world. This is a slide from a BMJ paper from Per Vatlik. He's from Norway. And if you start here at the bottom, I don't know if you see my mouse. Yeah, you see my mouse, good. So you have the evidence producers. So these are randomized trials and published papers. And then we have to synthesize this evidence into systematic reviews. And then we have to get this to clinicians. And then also to patients. And then we've got to find new answers. So this is an ongoing cycle of improvement. So actually, this is, I think, if you look at design and innovation, if you look at those things, and innovation, oftentimes the thought is of got a new implant. That's innovation in orthopedics or innovation in hand surgery. It's all about implants or surgical techniques. But I think the new innovation we're looking at right now is our innovation window is at the healthcare evaluation. So it's looking at research and looking at a different way of doing research and getting folks to collaborate and see how we can move forward to answer these unanswered questions. So actually you can see this is an ongoing cycle with the evaluation, guideline production and implementation. So if you focus a bit more on evaluation, so there's healthcare evaluation and also there's innovation. So I think these two stand together. So they're separate, but they have to stand together. So they can be not without each other. So but let's focus a bit more on healthcare evaluation. And I thought of, in my chair, I had to find 3 goals. So my first goal was to stimulate a research into healthcare outcome. So and how would you do that to stimulate this research into healthcare outcome? And fortunately, I'm very much supported by the Dutch Orthopedic Association, because we decided, I was in a committee that first made our first healthcare evaluation agenda. So our knowledge agenda, so with the unanswered questions, and it was based, our first base to a value-based healthcare system. And next, we've got the next level, the next unanswered questions, because the thing is, we didn't decide for a top 10, because you cannot really make a top 10. These are equally important questions. So now we've got a far bigger group of questions. And I think the next level we're going into is to make this modular. So because some questions are answered by other groups around the world, and you move forward with answering questions yourself, or some are just getting irrelevant. That's also happening. So these questions, they keep popping up. So you need to keep them relevant. And how to keep them relevant, this is also something we can learn from the British. This is the James Lind Alliance. And the James Lind Alliance, they really work closely with patients to ask patients, what are your needs? What are your unanswered questions? And they work together with clinicians, patients, and carers to discuss these research priorities. And also, I know you did it for the hand surgery. They also had the common conditions affecting hand and wrist and the top 10. So maybe, I don't know if you looked at these too. I'm not going to show the complete list here, but you can visit the website. It's easy to Google and see what they're doing, because this is pretty amazing. Because if you look at what they prioritize as research questions, it's quite opposite to what pharma does. Pharma has other research questions for something they want to sell. And these are questions that actually are important and that truly matter to patients. So that's why you need to get these patients involved as well. And oftentimes these questions, they're not standing alone. So what that's why I'm happy to also have this international thing going on here, that these questions are international, the patients are international. So if we collaborate on an international basis, we can start to answer these questions in a faster way. So this is just some of the things we are doing right now. We're doing the DART trial. That's a trial comparing a cast to open reduction internal fixations for displaced distal radius fractures in the elderly. This is a pretty difficult trial to get patients included, but we included about 110 patients right now, randomized between cast and open reduction internal fixation. And also this, we look at patient-reported endpoints that are important to patients. The Apollo trial is a trial for Hemi arthroplasty for hip fractures, 2 different surgical approaches. So far, we have the most patients included, the biggest study worldwide, but we're still not there yet. And also we do some, we'll get to that a bit later, to some registry nested trials. That's really interesting. I think in the Netherlands, we have these registries we can use as an outcome instrument. So, and then we published one of our, well, you don't always make friends with this type of research, but because especially if you compare surgery to non-surgical approaches. For instance, we did a trial comparing physical therapy to knee arthroscopy for degenerative meniscal tears. And the physiotherapy worked equally well. So, and even it was cheaper. We also did a cost analysis. So, well, this is sometimes a bit scary for orthopedic surgeons if we take away their bread and butter. But if you really want to focus on the patient care to get a patient improved, then we need to do this type of research. And then one of the things I'm really proud of is our arthroplasty trial, Hemi arthroplasty compared to total hip arthroplasty. We published in the New England last year. And this was a trial, you need to know, this is not a trial that is easily done. This was a trial that actually took us 9 years to conduct. And we included 1,400 patients, and it cost a lot of money. So we had a lot to get a lot of funding, and it took us 9 years. So this is not your easy, just retrospective study, but trying to get these true answers, it needs to take time, and you need to do a lot of endeavors. So now let's talk about guidelines, because these the results of these trials, they will end up in guidelines. And what we did is our rapid recommendations. That's a new thing that was actually introduced by the BMJ, the British Medical Journal. And it was a new trial, Sparks systematic review. If there's a new trial that actually shows a different result from treatment, and this Sparks systematic review, and this is translated into a guideline using the GRADE methodology. For instance, there was a trial that showed that low intensity pulsed ultrasound didn't do anything for fracture healing. So we looked at the total body of evidence, and then we make a recommendation. And this was actually a strong recommendation against the use of this low intensity pulsed ultrasound, because it was not just this one trial that showed this evidence, but this series of randomized controlled trials, they didn't show any effect. And based on good quality evidence, we could say, well, we need to stop this. You can imagine how happy the companies of these devices were with me. It's not happy. So if you can see, we split this up in all the different clinical questions, and we weigh the evidence for this. Next, we went to shoulder pain. Actually, we need to complement the finish, because the finish, they're the guys that do actually true science. They do placebo-controlled surgical trials. And they also did a trial comparing subacromial decompression to just placebo sham surgery. And this was the trial that sparked this guideline. And also, we found no difference. So there's a strong recommendation against the use of surgery for surgical decompression. So now, do we need to worry? There's also a lot of studies that show that surgery still is effective. But if we want to survive and we have our insurance companies that want to pay for us, we need to show that what we're doing is actually working. And that's what our patients obliged to. So then we need to go to implementation. So you have got your guideline, and then the next hard thing to do is to implement this into daily clinical practice. Because one of the questions is, well, does this evidence apply to this one patient that's sitting in front of me? That's the question, of course. So we need to stimulate implementation, maybe by best practices or just another way. I will get to that a bit later. But we are fortunate to have a value-based healthcare program. And we're running it on hip osteoarthritis. And we published this report on the hip osteoarthritis project. And what we do, this is in the Santion hospitals. There's 7 hospitals across the Netherlands. We make a multidisciplinary team in each hospital, and also patients are involved. It consists of physiotherapists, physician assistants, nurses, so everyone who's involved with the care about these patients. And then we have a standardized scorecard where we look at the outcomes. And then we have improvement cycles. We collect and find the data. So we analyze these data and to see if there's a variation in this data. And we look for improvement opportunities. So if there's a lot of variation, there's room for improvement, because why is this? And then we start to do implementations of this improvements and see what's happening. And then we collect the data again to see if something is changing. So we run this every 6 months, and we're doing it about 4 years now. And we discussed this, and I think this really works well. But the danger of doing it like this on without experimenting, just observation data and just starting to introduce stuff, may result in regression to the mean and also data lost and stuff like that. So we need to find better ways for this, and I'll get to that a bit later. So, but this is one of the things that is important, that a patient says, well, actually one improvement point should be supported by a patient. So if it doesn't matter to the patient, don't start working on it. I think patients are key here as well. This was one of our patients. These are the hospitals that are involved. And you can see there's the Netherlands is quite a small country. It's the same size as LA. So we're really close together, and that's why I think we can do a lot of good research in the Netherlands and move things forward. So education is the next thing. So what we're trying to do is to do research courses, writing old-fashioned books. I think that's not the best way to move forward, but we'll still do it. And then there's the Ortho Evidence website that was started with Mo Bandari. And there's a group of people that are doing systematic reviews and evaluating new trials. And so if you want to follow the latest evidence, go to Ortho Evidence. There's also a hand section. So I would recommend to follow that. If you don't want to be overwhelmed with all the literature and find good evidence, go there. So as you can see, we're trying to work in a plan, do, check, act way. So this is a circle that's keeping moving and moving, and it never stops. That's also a good thing about science. It's never stopping. And there's always new ideas, and you meet new people with better ideas. And if you collaborate with them, you get, well, better answers, and it makes more fun. So this is some of our collaborations. It's not fixed to one university, and it's not fixed to one country. And we try to do this internationally. So the generalization of the results is even better. So let's talk a bit more about innovation. As I said, innovation is not just a new device. Innovation can be also new research, new types of research. And for instance, if we look at natural experiments, there's a lot of natural experiments out there. And what we found is that in our registry, there's hospitals that use single shot antibiotics for hip arthroplasty, or they use 24 hours of antibiotics. So, and this is actually just by chance. So this is kind of a natural experiment to see what's going on. And then you really are trying to to answer questions with big data, because if you have the registry, there's about 400,000 hips in there. So, and if then you talk about numbers, and that's one of the good things. If you have 99% coverage of all the implants that are used in the Netherlands, then you can really start doing these natural experiments and looking at big data. Also, we use the Apollo trial, for instance. That is where we look at the posterolateral approach for Hemi arthroplasty, or the direct lateral approach, because we learned that these two approaches are the most frequently used types of surgery. And what we found is that some hospitals, they use the posterolateral approach, and others, they use the direct lateral approach. So the thing that happens if you fall down and you break your hip, you get transported by an ambulance to one hospital or to the other hospital. And this is actually also a natural experiment. So the treatment you get is decided by the location where you're falling. And to actually see if this is truly working as a natural experiment, we're running also a true randomized controlled trial alongside these natural experiment trials to see if we find the same effects. And the good thing with these natural experiments is that you actually include all the patients, not just the patients that were selected to meet the inclusion criteria for your trial or are excluded, but all the patients, also the patients with dementia and alcohol abuse that were usually excluded. So usually we exclude patients that we need the answers most for, because these are the difficult cases we try to treat, and we don't really have much evidence for them. So that's what we're trying to do now. So as I said, randomized controlled trials nested in the our LRI is the registry. One other study is the dual mobility cups versus standard cups for hips. And we are randomizing 1,100 patients to see which will result in less dislocation. And the good thing with the registry is that we can follow these patients as long as they're living. So this is a trial we look for the first 2 years for the dislocation rate, but then we can follow these patients as long as they live. So it's not just the short-term follow-up that usually is used, but we can bring it to the next level and use the registry as an outcome instrument and see how they're doing in 10 years. So also the Apollo trial for the Hemi arthroplasties are in there. So, but if you go to the next thing, if you have a new guideline, then it's hard to see how the guideline is working. So maybe we should do a hybrid effectiveness implementation design, and we can look at the stepped wedged cluster randomized implementation. This is a mouthful of words, but I think this is the new way to start doing implementation. So if you have a group of hospitals and you start with a new guideline, then you can randomize 2 hospitals to start with the guidelines and do your PDCA collection of data, see how things are going. Then you randomize another 4, another 6, and you just start off just slowly with the implementation of the guideline and follow the patients that are in these hospitals. They can see the effect of the guideline and build evidence on real world data, because oftentimes the trials that we're doing right now are just looking at these specific patients. So this is, I think, this is my last slide. This is what I'm working on right now, to find a way to find evidence for all the patients. And with this stepped wedged cluster randomized implementation, I think this is a way to move forward. So I think this was it. You can see it's a big circle. It's a lot of things involved. I hope you didn't get too much nausea out of this, and happy to answer questions.
Yes, thank you so much, Rudolf. Really impressive presentation, and impressive how you managed to act as science collecting and then translating it really into patient-specific recommendations, and really, really impressed by it. And I think we can still learn a lot from you orthopedics surgeons on how to do this type of research in plastic surgery. We're not there yet, I think. So
I actually got one question for you guys, because now we've got this research agenda, and this was actually one of the questions that was by Juliet as well. So how do you deal with the different specialties? Because we have got the same questions, we have the same patients, just a bit different specialties. But how can we start to collaborate in answering these questions? How would you, what would you recommend? Maybe the audience can reflect on that as well. How can we collaborate more with, I need to give a talk about it, and I thought I would just do a Q&A to find some perspective.
One of the questions to you as well is, you always need carrots and sticks in order to make people move, right? And usually the carrot works best.
Yeah.
So what's your favorite carrot? We have examples from the UK where the research, the RSTN is a system where trainees are involved for survey research, and they only publish where in journals where collaborative authorships are approved. So this way, even people that say you collect cases and 500 cases are collected. If you collect 10 cases, you're going to be a collaborative author. And I really like that model. What is your thought on carrots?
Well, carrots, I think group authorship is really important. As you saw in the New England paper, there were no authors, just a big group of authors. I think that's critical. So it's you need to work with people that don't have too big of an ego. So it's and carrots are of course also you need to get funding for this, of course. And the question, what is your favorite carrot, isn't answered yet. This is one of the unanswered questions. So what we're trying to set up is to do a trial to answer this question. To, for instance, to get a per patient fee for to include patients in a randomized trial, or get authorship. So we're trying to do an experiment on that to see how we can people get involved mostly the best way.
In the UK, that's actually the case, that where people get money for including patients in trials.
Yeah.
And that was one of the main differences when we started to collaborate with the UK, for instance, on pressure source, setting up a study in that way, that the UK participants would get funded in some way and the Dutch would not. But usually money goes after.
So we have this Apollo trials and the DART trial was talking about these trials are way running too long. So then they're funded by the Dutch healthcare SonMW, and they really get obnoxious at some point that this trial is running so long. So there's a slow inclusion rate. And now this is a new thing, the inclusion speed up funding, and we purely use this money to fund our participating centers and to really get the per patient fee. So also for the residents that are on the ER, including these patients, so they get they get money to have their skiing holiday or stuff like that. So and also we reward prizes, so if you include some patients in the DART trial, you get a dart board with the dart arrows and stuff like that. So that it needs to be there needs to be some catchy, funny thing about it. Just it needs to be fun. That's one of the critical things, I think.
And also
the being part of a group of bandits. That's also one of the bias detectives.
And how about including the private sector? Because orthopedics also has quite some private hospitals now.
Yes. Well, actually, we are making a bit of moves towards the Xpert Clinic. And one of the good things about the Xpert Clinic compared to other private clinics is that Xpert Clinic, the group of orthopedic surgeons that work there, they're also doing research. And I know the hand surgeons, they do a lot of research. So I think there's a lot of opportunities that if you have a setup that you don't have to do all the work yourself. I think that's critical, that you have other people help you, like research assistants. So one of the things I can share with you is how to get money for a research assistant. So if you use a lot of implants, like we do as orthopedic surgeons, you're ripped off by definition. That's that you need to know. So if you start to negotiate the prices of these implants with the hospital, you can also negotiate with your the board of your hospital that a part of this money that you save by getting a better price, you can use to hire a research assistant. So that's what we did. So actually, this is how we started our research department, by negotiating with implant companies on the price and getting the shared savings for research. And also, I think we pay a cheaper price now than Xpert Clinic for our hips. So that's and we have our research nurses. So maybe we can share this thought with some other folks.
Exactly. So I want to move on to the next speaker, because this is a nice introduction for Reinier Feitz, who is the founder and CEO of the Xpert Clinics, and has a track record in research as well. And I'm really excited to learn more about the system that you have, and the research and science that you're being created at your clinics. For those of you who don't know you, you're you're the founder of the Xpert Clinic, which is a private clinic chain in the Netherlands for hand surgery. Thank you.
Yeah, well, Thierry, thanks for having me tonight. It's a big opportunity, and many thanks for that. Big data is coming now, and Rudolf has shown that already, that the big registries are coming out, and we can all profit hugely from that. And when we started out, it was almost never done. And I was always wondering, why do we start each and every time again with another cohort, a new study? And why can't we use each and every patient as a study? And why can you continue with doing all this research? So that was basically one of the ideas. And if you read a small print there, you can see I've become a PhD candidate after these many years, 25 years of my professor Hovey is questioning me about it. But here's one, I'm going to do it next year, and you're all invited. Anyhow, we all know this is a learning cycle. So I'm not going too deeply into the why now. Why do we need to learn? And I think another part that's not been mentioned, we need to learn as an individual surgeon of our own results. So if you have a group authorship or a group publication, you don't see your individual results. So one of the things we achieved is to really give your own data back to each and every surgeon. So it's a bit been introduced, but these are our core values. So we really like to measure our quality and do scientific research with it and educate people. And we were founded in 2008. And for the people who are not from the Netherlands, we have a few locations now and a lot of hand therapists involved, and I think that's key to really work with the first line or with the hand therapist and treat patients as a group and not as a surgeon only. And I think we do more conservative now since we were working so closely together with these hand therapists. So this slide in Dutch, sorry for that. But what do? We do measure a lot of tracks, and we were figuring we have many diagnoses, but we need to have just a few ways of scoring the outcome. And we made these tracks, and you see that the Jupitrans, their wrist, their nerve, their thumb, and short and long. And so everything in the end funnels back to a small group of set that we acquire data on. And here you see the growth in the data over the years. And we started with the experiment way back, but only in 2012, after 6 years of trying, then we really got it going, and we measure from then on. So each year we add data to this. We get data on data, and it grows and it grows. It's not lost. So then you end up with a lot of things, and you can achieve a lot. Now, the what is already been answered now as we achieved the ICHOM set. And big thanks to Robert Wouters of our team, did a lot of work on that. And there's a big international group that decided on the things we should measure, and also when we should measure this. Because that's new for ICHOM. They usually only debated about the sets that you want to do your research on and your outcome on, but also when in the time. And we decided on a few things that you should be able to measure. And they're both reported by the patients and by clinicians. And I think that's crucial. And I would advise you to get the hand therapists involved to do these measurements, because they're better at it than we are. And they probably are also better in really doing it. So from the beginning on, we tried to have all the data input being managed away from the surgeon into other fields. So there's been some discussion about cost already and how we're going to do that. And we started out with just the two of us, but really want to get these things going. And actually was the key thing for leaving the hospital. So I think the organization asked me today, so it seems a contradiction when you work in a private clinic and you do so much research. And actually it's not. It was actually the driver of going out of the hospital. When you ask any entrepreneur, if you focus on the profit or on the money, you will end up broke. You need to focus on the value. So we really want to get this out and communicate about it and do research with this. But how? So we started to look at the things we could do online with the patients entering data. And thereby you move it again away from the surgeons and you get automated data collection. And so we did all these things on the prompts and the prems, and to give you any idea on the scope of the total amount of data we collected with the group. And I really need to address our science group now with the Erasmus University. And we always work together right from the start. I mean, we do the work in the clinic and we organize a lot of it. But in the end, we need the scientists to really look at the data. So how are we using it nowadays? What do you do with the data? Because in medicine also notice that people are really focused on getting the publications and the papers out, and then full stop. But it should be used to really improve the medicine and improve the clinical care you give. So what we do now is we have a journal club, for instance, and at the journal club, and I invite everybody to join. It's open for all the Dutch plastic surgeons, and orthopedic surgeons are welcome, of course, as well. And we have scientists present at these meetings, and we can look at our data real time and decide when we read a paper together whether we want to do this, take it over, or measure it, or do a test on it. So that's one of the great ways we use it. And the other thing is the surgeon evaluation. Every 6 months, each surgeon has an individual evaluation where we show the results of some of the surgeries they do and how they perform against other ones. And people like that. They are competitive when they work in our group, and they like to know where they stand and how they score. And basically, it's not as frightening as it may sound, because in the end, we all have the same results. And it was a lot different than we had expected when we started this experiment. So the patients are different, but the surgeons, in our group at least, they deliver the same quality. So we also try to give back data, and it's one of the hardest things in the whole experiment is to, what are you going to do with the patients? How do you get them to participate? What are you going to return for value for them? So we now use it in the consultations. We share our data and our own outcome on every surgery, or to convince them to not have surgery because we have the conservative data as well. So these are all great advantages. And big shout out to one of the participants here, or two. I know Mark is present, and Ruud Selles, the primary author of this paper, has been recently published in PRS. And it is very good if you want to get into this, how we've done it, because it's really a good summary of the things we achieved and how it's actually been done. And we needed it because we got pushback from reviewers on our papers. So the Netherlands is a very small country, and how can you have so many data, so many patients must be made up. So this helps a great deal, I think, in understanding what we've done and how we get into these numbers. So one of the other things you can do once you have this database is to do rapid iterations, to really speed up your research cycle. You only have to do a small sample and then compare it to the other ones to see if what you've changed is really working. So that's the back test. And it should also allow for A/B testing. We're not doing that currently as much as I hope to, but I'm sure we're going to get to that. And we're going to lead patients through different websites or different treatment protocols. And what are the challenges? What is the outlook for the next few years? I think we should really try to get the compliance higher. We're now around 50, sometimes 60%, but if you would crank that up to 80%, then you would do a routine level 1 study. So that's mind-blowing, and I'm sure we can achieve that if we get the patients to do this. But and it's really hard to get it up to 80. But it's interesting that the normal randomized controlled trial might not be in the end the best thing. I think it's really important to have day-to-day data and in the real clinical practice, and not just in some landscaped research setting. The other thing is the growth and the scale up, because the group is getting larger, and it's already been mentioned. What do you give back to the authors and to the scientists involved? The group authorship is very important, and some papers are really reluctant still to address that. And that's why we started out with the hand-raised study group to really name and give a pledge to all the participants that are involved in the studies, all the surgeons who may not have anything to do with the research or the write-up of these articles, but are important every day to treat these patients and like to be rewarded with a co-authorship. The other thing is we're now starting out to do some international collaboration. We already did that with the research with Harvard and Oxford and Rabat and some other participants. But we're now running the same software in Swiss with Maurizio Cogani. And we hope to really compare in the end the results of our center with other centers. And this may lead to other joint publications. And there you see the word that has already been mentioned a few times this evening, the ego management, because the more people get involved, the more you need to share your data with other ones. And it's important to close the loop. So what we really want to do is do dynamic real-time prediction of treatment outcome. And we've got that installed now in our website. So we not only get back the data of our group, but we also try to predict what the outcome is in the end of each individual patient. So all the patients ask us, how are you going to do it? I'm still feeling pain, is that normal? So they can compare it against the group and they can see where they go. And we want to add on that, on top of that, which is not really functional on every treatment modality, is a a personalized outcome. So to give you an example again from our group, this is really experimental nog. Still, this is based on our own data. It's for carpal tunnel, it's quite simple. And if you write that website down, you can try it for yourself and enter your Boston questionnaire and how much pain do you have? Do you have any problems with local anesthetic? Are you a smoker? And then we predict the outcome of the surgery for you as an individual. So I welcome you all to try this. And I think that's one of the great things you can do. And I hope that our group is willing to accomplish that for a lot of other diseases or treatments as well. And the organization also asked me to give some tips for starters with you. You know, this all seems like a very big experiment, and it is. It's grown into that. It's grown into another science factory with a lot of papers. But you start with one thing, you know, measure one treatment, one modality, and then scale up. You do need a platform. I think I would advise to stay away from electronic patients files or hospital data, and create your own layer, because you probably are able to move a lot quicker. And aim for publication, because the scientific and peer-reviewed papers in the end will drive the science, and this is the highest quality of data, and you can answer all other questions if you publish. So you can give data to your insurers or to the patients or to the management of your hospital. But in the end, you should aim for these papers. Then I've got some singularity credos, the demonetize and democratize. And that's really about giving back the data to the patient, because it's not about publishing, it's about improving the data for your patients. And why demonetize? Because there's always money involved in research. And we are investing a lot in our research and in our group and hiring PhDs and all that. But in the end, I think it's added value, and it should be aimed for improving our healthcare and not for getting more publications or your own ego. So I hope that it's helpful, and it's a very short presentation, and I welcome you all to give me a call or reach out, and we can discuss it further on. Thank you very much.
Thank you, Reinier, for this very nice talk, and really nice platform that you developed for measuring all these patients. Are there any questions from the audience, Juliette?
Not yet. But I think it's quite remarkable that you've set this up in the private sector, especially with so many papers, but also so much knowledge that you've gathered. But if you would do it over again, would there be lessons that you would do it differently?
Yeah, well, maybe a lot of things, you know now, and I don't know. We started out with really trying to examine what we want to measure. So by going through all the hand therapists and see what everybody was measuring. And the good thing is that in the end we made a decision, and that's one of the hardest things about the Dutch society or larger groups, or that they need to address each and every opinion, and sometimes that's not helpful in reaching your goal. So in that part, it's in the end, again, comes an end to have a private clinic where you in the end can make these decisions and decide whether to go left or right. That speeds up things. I think maybe we should have reached out sooner to other people to get do the scale up, to get more people involved and to do more research. So we were doing this all on our own, getting our data, and we were focusing only on three things in the beginning: GP trends, thumb base, OA, and nerve. Because if you focus on more things, then it's difficult. But we still collected data on a lot of other disorders, because we collect data on all these patients, and in the end, other groups came in and they So how can we look at your scaphoid non-unions? Can we look at your Brunelli's? And that got us more papers. So there's a lot of data still that we've collected and is unused. And I think if we could speed up even more if we were able to share that. But again, it needs a lot of attention of our group, and especially from Lucelles and the management group and Ovi and all the others involved to give that a place and to manage that and to check up that the data is being used in a proper way and that it's good science and all the analysis is right. So the more people involved, the more complex it becomes even more expensive probably to manage. So that's still a problem for us and science in general, that is the funding. We don't have expensive implants we can put in, so there's no money to be gained there. And that's I think different from the field where Rudolf is operating in, because hip arthroplasty is also for population important, and you can't go through the doors with collecting money for Jupiterans. People will not give away any money for research for that. So that's one of the problems. That's why we did it such a poor way and only got all the data from the patients, and the patients are really doing all the work for us.
And one of the problems also so far in the public sector is the direct feedback for patients. Especially the software development is not always as good. What kind of decisions have you taken in your private sector on the software side?
Yeah, that's a good question. So we designed our own platform. It's open source. And then we took the open source bit and started developing it in our own purpose. And I think we spent a lot of money in the end over the years to get it right, and to connect with it with the website. So when I didn't have time to show that, when you're patient with us, you get an individual website which shows all the data from you as a person, but also for the from the other the clinical results of the whole group. And I think that's a huge advantage. And it also taps into the patient record and about visits and about other stuff that's been organized elsewhere. So it's like an open backdoor in the end. And you need that to really address all the issues. You need to get data from the electronic file about when the operation is or when the visits are. And that triggers our program in sending all the questionnaires. So that's the hardest bit, and you need to, I'm really thankful to Harm Schleiper and all the other people involved that made it happen over the years. And I think that's, in the end, that's, I think, the biggest advice, that we took our own steps and decided on owning the software and not giving it away. And that's demonetized as well, because if you give it to a company that will sell it, and then in the end you will end up without being able to develop this any further.
Okay, well, thank you very much. Does anyone have another question? Not coming in.
Maybe I can comment on Reinier's remark that you don't have money. If you look at, I think this is really important work you're doing, because if you look at the quality of life that is gained by your interventions, this is building value for patients. And I think if we can explain this to Sondenweg and other like the rheumatology Netherlands and stuff like that, funders, then I think it is possible to get funding. Okay, it's if you are a caregiver or
we're conducting a Sondenweg study now, and multi-center on Tomaway, and also we're involved in the application for the cubital nerve with the neurology group from the VU AMC. So it's happening now, but yeah, well, and we have been getting some funding from the beginning. But it's really independent. It's not industry funded.
Yeah.
Maybe I've got a question for you. Do you have any tips, Rudolf, on the group authorship? Because that's still bugging us a little bit. How are you going to organize that? Can you really? Was it hard for you to get it done with the BMG or New England? What was it to have this group authorship? How did you manage? Was it your thing, or did
well, there was a pretty much led by the Canadians, the New England paper. So you have a writing committee, and the writing committee writes the paper, but all the participating centers, they can have a surgeon as one of the group authors. So it's just be inclusive. Don't exclude people who are working in the study. If you include as many people as possible, it builds you credit for the next study, I think.
We've found, particularly with the Science of Variation group, we have a group authorship for everybody that gives their time to do the survey, and most editors approve of that and put it on PubMed. I've seen people's CVs come through where they have 10 papers and 5 of them are group authorships. For that's not going to get you anywhere. But the other thing is that like some of them will well, we always do that group authorship and also some named authors. So that's how you might do it in expert clinics.
Yes, and as long as you have enough papers, if your output is so high, then it's easier to share the authorships. I think it's.
Now you just got to get Sebastian to start writing papers again. This is one of our PhDs that works there. If you guys, I would love to see you guys do some studies, and you probably have the data on some of these questionable nerve diagnoses like radial tunnel or pronator syndrome, things like that. That's a great interest of mine. I find that in hand surgery we tend to invent a lot of diseases. I'd like to see if those are anything more than flim-flam, to be honest.
You're more than welcome.
There's my provocation, Thierry.
Well, that's not a really standardized treatment, I think, and a lot of variation there, and you probably you address that. So that's interesting. And I think it would be great to get data on that, on when to operate, especially with a lot of these nerve entrapments. Yeah, you're most welcome. And Sebastian is involved, Sauer for the people, the other people, yeah, and he's getting back into it, and I'm really pushing him. And he's doing 2 papers now, and doing 2 papers with him as well. So.
Great. Well, if there are no more questions, then I think we should end this webinar. I would like to thank all the panelists, all speakers for your time and your effort from preparing your nice presentation and sharing your thoughts and ideas. I learned a lot today, and I'm really excited again to start working on more research projects. So it was a lot of fun tonight, and I hope you enjoyed your evening as well. So goodbye. I think we should end by now.